would I'd very much like to welcome you all to the Midlands Analyst Network Huddle, and it is a lovely sunny day here in Stafford, and I hope it's nice where you are. So for any new people like Hayden and Rachel, we hope you'll find these huddles useful by sharing skills and learning from each other's knowledge and experience. But I may have said this before, I just think these are just a really, really nice place to be. So there's more info about why we established the network and the role of the huddles in the file section of the Teams channel, which most of you can access. And we're always looking to improve the sessions. So please do feedback if you have any great ideas, and especially if you'd like to contribute in some way as well. We'd like to get more people involved if at all possible. Anyway, thanks. Thank you. Thanks very much for coming today. As always, it's absolutely great to see you all. And in today's huddle, we've got Stephen Wyatt, who's the head of research and policy at the strategy unit. And Stephen's going to be discussing the analysis of primary care services. So ICSs will soon be assuming responsibility for commissioning GP services. And although 10% of the NHS budget is allocated to primary care, novel analysis of the service are few and far between. And analysts often say that the data access is a key restraint. So Stephen's going to be talking to us in the session, and we're going to be exploring those opportunities to improve and extend analysis of primary care services. I won't say anything more about the session because I'm sure Stephen will be covering all of that, but I'm very much looking forward to that in a moment or two. So you'll notice that we are recording today's session, and I'll also share any slides which are available after the session, and the recording will be on the Teams channel and we'll be putting on the website too, so those who missed it can catch them later. So we're going to finish around 12 or before. If we finish before, we do. And if you have any questions or comments throughout, please use the chat box or shout out, and Stephen is going to be making Menti available for you in a moment or two so that you can interact with us even if you don't have access to the chat box, because I know some of you don't. So please keep yourself on mute, and if you do want to say anything, just say. And as usual, these sessions are for you, and we do like to keep them as informal but hopefully as informative as possible. So you'll be delighted to know that you haven't got the usual go to my Menti screen and answer my questions, but what we do have is a much more sensible Stephen, and he's got some Menti for you as well. So you don't get away from Menti. But I'm now going to hand over to Stephen. Stephen, welcome.
Thank you very much, Rachel. Thank you very much. And thanks everyone for coming. So the usual format for these meetings is that somebody would present on a project they've been working on or completed recently, sort of share their sort of findings and methods and get some feedback. This session is going to be a bit different. So Rachel's been running these sessions for what, 18 months now, Rachel, is that right? Something like that? And attendance is always great. You know, even on half-term week this week, we've got nearly 50 people here. And I'm always really impressed by the sort of spirit of sort of mutual support and cooperation that you get when you attend one of these sessions. And Rachel and I have been wondering about whether we might build on that a little bit more in the future. So I've got a couple of propositions for you today. I wanted to run those past you, get your feedback on them, really see if there's appetite for taking forward this way of working into other avenues. And the two propositions relate particularly to whether we might collaborate more on shared analyses of primary care services. That's the kind of idea. So I'll run through today a few slides. I've got a few Menti questions for you just to set the scene and try and gather a bit of information about you and current state of play of primary care analysis in your area. But I'm really interested in having a discussion with you about whether the ideas I'm putting forward to you are of any interest to you, really. That's what I'm trying to do with the session today, test your appetite for collaborating more on primary care analysis. So I'm going to just start sharing my screen, if you bear with me. Oops. That didn't work. Try again. There. Can you see my screen now? And if I do,
yeah.
If I do that, can you see in PowerPoint slide mode now? Is that right?
Yeah.
Yep, great. So if I could ask you to go to www.menti.com and enter in that code 11525553, Rachel, would you mind putting that in the chat as well, just so people have it there as well? And then the first question I'm going to ask you when you get in is about where you're currently working. So you can select multiple areas if you're working across more than one area, just so we can get a sense of the distribution of the attendees across different ICSs in the patch. Okay, so good contingent from Nottingham and Nottinghamshire. They're always well represented at these meetings. It's great to see. In fact, someone here from at least one of all of the ICSs, isn't that great, in the Midlands? That's really good to see. And a few colleagues from outside the Midlands too. Okay, there's a few more answers coming in. Lovely. How many people have got on the call, Rachel? Do you know? Is it about 40?
I think it's quite a lot more than that.
Is it? Oh, okay.
I've got to add two numbers together, Stephen. Just bear with me. Hang on. 50 plus 18.
Okay. Well, we've got 44 responses, so I'll move on to the next question. I think that's probably most people.
That's great. Yeah.
So the next question relates to what sort of organisation you work with. So are you working for an NHS trust, a CCG, SDP or ICS, a CSU, local authority, university, or some other institution? This is good again. We've got good representation across all the different organisational forms. Nobody here from a university, it seems. That's unusual. We usually have one or two university colleagues here, but that's lovely. Thank you very much. I'm going to move on now to ask some questions about your sort of experience of working with primary care data sets. So I want to ask, thinking about your time, your working time last year, how much of it was spent analysing primary care services? So I've given you, I think, 5 categories there: none, less than 10%, between 10 and 25%. Oh, I've got 2 lots there. My category 3 should be, sorry, category 4 should be 25 to 50%, shouldn't it? But anyway, and most. You'll excuse my error.
Stephen, you are excused, but are you able to share your screen so we can see the results?
Oh, I thought I was. Am I not?
You're sharing the Menti code, which is very useful as well. Right. She says
thank
generously.
You, is that working now?
That's loads better.
That's great. Thank you.
Thanks.
So so most people are saying they do none or very little primary care analysis, but there are quite a few people here doing more. But I guess that might be self-selection. The people who are attending the session today may be those people who tend to do more primary care analyses. Right, I'll move on to my next question now. My next question relates to recent analyses of primary care that you've worked on. So if you could just maybe give a sentence or two, or just a few words even, on the sorts of analysis that you've done recently of primary care services, that'd be really useful. So we've got people talking about, I wonder what WAF access data. I'm trying to think what WAF is. Could someone tell me what WAF is? Should I know that already? This is great. This is really useful. So analysis of QoF, GP access, referrals, variation in referral rates, risk stratification, we've seen segmentation as well, access, farmer needs assessments, vaccinations, activity trends through the pandemic, analysis of pilots on community pharmacy and the impact presumably on GP services. This is really helpful. Thank you very much. This is really useful intelligence for us. Maybe it makes my opening gambit about not much primary care analysis going on. Maybe that should be questioned now, seeing these results. But Okay, thank you very much. I'm going to carry on just one more question, I think, before we break. Oh, a couple more questions. So if thinking about the sorts of analysis that you're doing at the moment, what would you say is the main barrier to doing more or more interesting primary care analyses? Okay, I think we're getting the strong message here that the primary issue is access to data, that people will be doing more if they had better access to data. A few people saying sort of lack of demand, lack of interest, or restrictions on their time, but I think we can conclude the main issue here is access to data, which is good. That fits with the session. And my last question before we move off the Menti is about, oh no, I've got two more questions. How well prepared do you feel for the ICS to take on responsibility for primary care services? Okay, here's a mixture of responses here, but I think we can conclude that people would rather feel a little bit more prepared than they currently are. Obviously, some work been going on to prepare things in advance of the change in responsibilities. And in fact, some SDPs will have already taken on responsibility last year or the year before. So I'm guessing some SDPs and ICSs are ahead of the game here. That's great. And this is really my last question now, Menti, which is about the balance, thinking more generally about your work as an analyst in the NHS or in local authorities. What would you say is the balance of responsive to proactive work in your average year? So I'm thinking about responsive analyses being those that are produced that others have requested and specified, whereas proactive analyses are things that you've thought up, imagining that others will find it useful. So yeah, which of those two categories would you say most of your work falls into, either responsive or proactive? And what's the balance of those two things across your workload? So I think we're here again. The conclusion is that probably half of you are saying that most of your work is mainly responsive, but maybe the other half are getting other opportunities to do more proactive work in your STPs and ICSs, thinking of analysis that other people might find useful and taking those forward, hoping they'll land well once you finish them. Yeah, that's really helpful. Thank you. So I'm going to stop sharing my Menti screen now and go back to my slides, if I can work out how to do that. Okay. So can I check you can see my screen again now? Is that all right? Yeah. So as Rachel mentioned at the beginning, the NHS budget, 120 billion or something like that, and about 10% of that is spent on primary care services. Actually, the number is probably slightly bigger because that just counts the main GMS, PMS contracts, and there are quite a lot of other funding routes for GP services that wouldn't be captured in that. So a significant proportion of the NHS budget on GP services. And from a patient perspective, it's the service that they most readily associate with. We do something like 300 or 350 million appointments per year. That works out about 6 appointments per patient per year. I'm always surprised at that. But yeah, the numbers do seem to bear that out. And some people are using, that's the average, so some people are using it even more heavily than that, substantially more heavily than that, seeing their GP maybe every other week. And GP practices employ something like 14,000 staff. So they're a significant part of the NHS infrastructure. And again, just to make the point that from a patient perspective, they're the service that most people would associate with. They're probably the service they'll think most about when they're thinking about the quality of the NHS and the service they receive, just because of the level of contacts they receive from GP services. But GP services are facing a number of challenges. They have done for a while, but those challenges are really ramping up at the moment. They've struggled to fill their vacancies for a number of years, particularly GPs. Many practices are reporting difficulties with financial sustainability and are looking at alternative funding models. Lots of experiments with models of care about virtual consultations, telephone consultations, Lots of experience with organisational form. Some GP practice has been taken over by acute trusts, others collaborating. We've got the development of PCNs, which may lead to further mergers in the future. Some primary care services have been taken over by private institutions as well. We have issues of staff burnout. The biggest issue I think that people talk about mostly in terms of primary care is access, and anybody who's tried to get hold of their GP, I guess in the last 12 months, will know how difficult that is. My colleague Stacey Cross has been working on a project which tries to understand the difficulties that people have getting through on the phone first thing in the morning, and she's been trying to understand what the rotas need to look like to really provide an accessible phone service to patients who are phoning in. But the level of access people are getting over the phone is really troublesome at the moment, and that's just to get through on the phone. To get an appointment is another hurdle to cross. And all of those problems were around and have been around for quite a while, and then COVID came along and really emphasised some of those challenges. So, you know, we're anticipating substantial change in primary care services over the next few years, and at the same time, ICSs will be taking on responsibility for commissioning those services in the next few years. So the challenge gets handed over from NHS England to you in the field. So what I wanted to talk about today was whether there might be opportunities for us to work more collaboratively together to produce insights into primary medical services, into GP services. And anticipating the responses to the Menti questions, I think the biggest challenge here is data and data access. That's certainly been the challenge I've been faced with when trying to do work in this area. And I think the responses to the Menti questions bear that out. So I wanted to talk about the data that's currently available, and I think they fall into two forms. There are GP practice level data sets that are available in the public domain, aggregated data sets relating to GP services that are publicly accessible on various websites from the national organisations. And then there are patient or record level data sets, which are much more difficult to get access to, but do exist in various forms. So I'm going to talk through about those two types of data sets in a little bit more detail now. Not that I regard this as my area of expertise, so anybody who's out there who knows these fields better than I do, please feel free to chip in and contribute to the discussion here. But starting first of all with the GP practice level data sets. So these are the ones, when I was thinking about preparing for this session, these are the ones that I'm aware of. I'm sure it's not a full list, but there's plenty of them out there. There are data sets which give you information about patient list size and demographics. Data sets about births and deaths relating to each GP practice. Data sets on deprivation of the residents or registrants of GP practices. We get data on disease prevalence, on appointment rates and types, at least at CCG level at the moment from NHS Digital. You can get data on screening and immunisation rates, on online service use. That's a relatively new collection that NHS Digital has started publishing. There are lots of data on process quality and intermediate outcomes that we can get via the quality and outcomes framework. Counts of activity relating to secondary care like referrals, patient admissions, A&E attendances, outpatient attendances, community health services, mental health services, all of that is available to be broken down by GP practice. We get data on GP reported use and satisfaction via the Ipsos Mori survey that's carried out on a regular basis. Lots of data on prescribing and prescribing rates at practice level. NHS Digital published staffing data for GP practices, again on a quarterly basis. We have information on the GPs that work in practices, their age, their sex, their length of service. Some data on infrastructure and the IT systems that GP practices use. Data on organisational status, whether they're a sort of GMS or PMS practice, branch practices, what CCGs there or PCNs they might be members of. On NHS Choices, the data on GP opening hours and accessibility, whether or not they've got ramps for wheelchair access or hearing loops, for example. And CQC published quite a lot of data on the regulatory status now of GP practices as well. So a large amount of data, I think, on GP practice level that's available on public domain websites. And I see quite a lot of analysis that use individual lines of these data sets. So you'll see quite a lot of analysis of QoF or of referrals or prescribing. I see less data which use multiple sets of this data, and that's partly, I think, because whilst these data sets are all available on the public in the public domain, the format they're in makes it just slightly challenging to download it, to curate it, to put it in a format that can make it easy to use. And there's challenges as well that the different sources of data use different reference categories. Some include some practices and exclude others. The time series are different. So bringing data sets together from multiple items on this list to bear on a particular analysis carries an overhead, a sort of data wrangling overhead, which is enough sometimes to put people off starting that process. Now, most of these data sets are made available by some of the national organisations, and some of them are already collated. So UK Health Facts, I don't know if people are familiar with the UK Health Facts, but they do collate a number of these data sets on a regular basis and make them available back to CCGs and trusts and NHS England and other bodies. And the PHE tool Fingertips also collates some of this data into GP practice profiles. But I don't think either of those things are complete. In fact, I'd say both of those things are fairly partial, that they contain some, but by no means all of these sources of data. So that brings me on to my first proposition to you, really, about how we might collaborate on primary care analyses together. So this is an idea, and I'm kind of interested in your reactions and perspectives to it, really. So what we thought was that we might, the strategy unit on behalf of the Midlands Decision Support Network, might collate and catalogue all of those data sets that I listed on the previous page into a really nice, tidy format and make them available in some location for the members of the Decision Support Network. So we'd do all the legwork that you would have to do if you were using 3 or 4 of these data sets in one go. We'd bring them all together into a single consistent format. We'd have all the metadata available for you and all the code that we'd use to scrape the data and assemble it for you so that you could check how we'd gone about that. And my thinking is that might just lower the barriers to entry, really, in primary care data analysis. If somebody else has already collated all those data sets for you, then your job as an analyst is just to think about how I can use them to answer useful questions. So that's the first thing we would do. We would kind of collate those data sets and make them available for you. Because they're all public domain data sets anyway, we don't have to worry about security, so there wouldn't be any particular issues relating to IG, I don't think, in bringing those data sets together. Next, we'd convene a workshop of Midlands Decision Support Network analysts, this group of people and others that might be interested, and maybe invite a few people from primary care services as well, to try and generate ideas for projects that we could use that data set to answer. Now, I normally don't suggest we start with data sets. I usually suggest we start with questions and then think about the data afterwards. But I think because primary care data and data access has been such a big problem for such a long time, there's probably a backlog of questions that we're aware of that we'd like to answer. So I think starting with the data isn't problematic in this sense. So we'd start by assembling the data, then we'd have a workshop to try and generate some ideas for analytical projects that we could use that data to address. Next, we'd try and generate some interest and demand from within ICSs to answer those questions that we'd generated. So we'd meet with ICS leaders and managers through the routes that we have available, and we'd encourage you to do the same, to try and generate commitment to take those projects forward and free up your time to work on them. Next, we would try and work out how to allocate the project ideas out to MSDN analyst members. So which ICSs, for example, might want to lead on particular questions on behalf of the network. So we could reduce the duplication of effort on these questions that we think might be of interest. Next, we'd sort of convene regular workshops for people working on these projects. Maybe we could arrange to meet once every couple of weeks just to update each other on progress and help each other resolve any issues they've got with either data or methods they're working on. And then we'd also make some platform available so that you could share your code with each other and the outputs of the work that you've been producing. And finally, we'd host and organise an event so that you could share the analysis that you'd been working on with decision makers and analysts, create sort of critical mass so that there was a lot going on in a single day. So we'd create quite a full agenda of lots of presentations on primary care analyses for decision makers and clinicians. So that's kind of my proposition for you. I'm kind of interested to know, is this something you're interested in doing? Do you think that you might be interested in working in this way? We were thinking if we were going to work this way, we'd probably start around September this year, with a view to holding the event maybe in the early part of the summer next year before we break up for the summer holidays. But the timescales are flexible. That's just to give you some indication. So I'm really interested in, I'm going to stop now and maybe pause for questions, but really interested to know, you know, is this of interest to you at all? Would you be interested in working collaboratively in this way? Do you have any suggestions for improving the proposition I put to you? So yeah, I'm going to stop sharing my screen and maybe open up for discussion again. And somebody's going to have to be brave and be the first person to say something now. But I'm going to sit quietly. Anyone's got any questions or comments or observations? Do you think it might be useful? I know you're a very polite group, so you know. But if it's not what you need, then say we need to hear that as well. But if you think it might be of use and you'd be interested in working collaboratively in this way, we'd love to hear that. And over to you. Any comments? Uju.
Thanks. Hi. Just to say, first of all, thank you for that. I was just listening to you and thinking, oh, I'll backtrack. Introduce myself. I'm from public health. I'm an acting consultant in healthcare public health with the public health team in NHSEI. I was invited to this meeting. I can see my colleague Alan Reed is here as well. So listening to you, I was thinking, oh, this is so amazing. Finally, someone's going to try and pull all of this data together. And I think one of the things, I might have missed this in what you were saying, but one of the things that I thought would be useful is when you're talking about that approach where you're getting together partners, so from primary care, clinicians, etc. I was wondering it would be useful to open up the net a bit wider. So I'm thinking like even colleagues from, like myself, public health and NHSEI, colleagues from local authority as well, they might be interested, especially considering the links with what we're trying to integrate care across the whole pathway and the whole system. So that would be one recommendation for me, but totally support the idea. Fantastic stuff. Can't wait to see it start.
Okay, great. Thank you, Eugene, and great suggestion. Yes. Yeah. Any other sort of thoughts or comments, questions? Are there questions coming in on the chat, Rachel?
Don't have access to chat here in my system.
Somebody's just answering my earlier question about some of the acronyms that we used in the earlier slides. So thank you for that.
I was just saying, but I was on mute, that Alan and I had a brief conversation, didn't we, about, so in your new role, so you're a public health consultant?
Yeah, the same as Uju. So Uju
Yeah.
and I are the same consultants in healthcare, public health. We've transitioned over from Public Health England to NHS EI in the Midlands. And we're both scoping out, along with other colleague that's on the call, Nathan Davis, we're scoping out primary care data to take a kind of offer to the regional focus of primary care. But of course, we're just completely bamboozled by the sources of data as you've described, Steve. So obviously that would really help us to take that forward. But yeah, as Uju says, we're looking from this the systems level approach or the regional level, and how we link in that primary care data across at the regional level with OHIDs and partners across with that. So that whole pathway approach. So yeah, anything at this stage, we're Uju, Nathan, and I are looking through the data, going, "Oh my goodness, where do we start?" And so yeah, anything would be really helpful.
Great, thank you, Alan. Ian, I think you've got your hand up. Ian Bates.
Hi there, yes. Ian Bates, Public Health Analyst, Nottinghamshire County. I've only really touched primary care data in supporting primary care networks from a sort of public health perspective locally. Just a reflection, pulling all this data together, it'd be great to use the data set. But it brings in also, I know you touched on this, that's whole now should all the data be available together, it's that what can be compared, what can be used together, and it's just building up that new knowledge set of, although it's all in the same format, be careful to do when you're looking at this, that and the other. But yeah, big piece of work, and echo what all the NHSIE colleagues said, a big nettle to grasp.
It is. I mean, I'm part was reluctant to suggest it because I'm aware kind of how big that data wrangling task is going to be. I've been doing some of it recently for a project, and that's what gave me the idea. I'm doing this. I bet other people are doing exactly the same thing somewhere else in the patch, trying to scrape all this data off, NHSE websites or NHST websites and get it into a form and work out where the duplications and overlaps are. And I thought, it'd be so good, wouldn't it, if somebody was doing a thorough job of that across all the data sets on behalf of everybody. I'm sure that would cut down sort of effort across the patch, but also open up opportunities that, if you've only got a certain amount of time to do an analysis and you're looking at a week-long job of the data wrangling before you can get started, that might be enough to put somebody off and say, well, I'm not going to be able to do that piece of work. Whereas if that work's been done up front, again, I'm hoping that it might just open up opportunities for others to start using the data sets more fruitfully.
Yeah, so Alan has his hand up. Alan.
Hi, just another aspect. I mean, I'm assuming that's going to be covering, the proposal covers the whole of primary care, so the directly commissioned services like pharmacy, dental, optom as well, because particularly the GP and the pharmacy work that's been done regionally in terms of the referral scheme between that, and that's something that Uju and myself are sort of looking at as part of our work. So it'd be really helpful to have that whole primary care, just adding to your workloads, Steve. Yeah. But as in terms of the spirit of integration across whole primary care, that we don't, obviously should include dental, optom, pharmacy as well.
Yeah. My understanding is the data sets for those they're more limited, but yes, so we may start on primary care and then add in the sort of pharmacy, optometry stuff as we go along. Yeah. But yes, I get the point. It's primary medical services are just one part of the equation, aren't they, for primary care?
Charlotte, you have your hand up.
Hi, yeah, it was just a comment earlier. I was trying to put it in chat, but I can't find the chat on here. It was to say, have you heard of Analyst X, which is run by NHS E&I? They might be a good resource to get some more brains if you need it.
Thanks, Charlotte. Rachel, I think you're in touch with Analyst X. Is that right?
Yeah, we sort of we're linked in. We're linked in with Analyst X. We have we sort of, for example, we look at our huddle content and when they are, and we see how they compare, and I steal people from them and they steal people from us. But we work together. So, but that's a great suggestion. Yeah, thank you, Charlotte.
Although I've talked to this being sort of a Midlands thing, I think the extra work in making it a national data set would be minimal. And then I think there are people, we would want probably to have comparator areas. So I think we'd just do it first and as a national data set. And the thing I should have mentioned when I was talking about the proposal was that I've talked of it as being a sort of comprehensive process, starting with the data sets, doing this ideas generation process, allocating projects out to ICSs, working together on them. But of course, if you as an individual just wanted to use the data set for something else and didn't want to be part of the collaboration, that'd be free for you to do that. Again, if you just wanted to come to the idea generation workshop, not be part of the other parts of the process, that would be absolutely fine as well. We're not, you're not compelled to be involved in all of it. But I guess what we're trying to do is get a sense of the level of interest across the network in doing it, because I'd want to be reasonably confident there was a cohort of people out there who are ready to go on this and wanted to take it forward. I know it's difficult to commit in advance. I'm not asking you to do that, but to give some sense of your level of interest. And I have got another Menti question that might try and gauge that in a minute, but have we got another hand up now?
Yeah, so Jack has his hand up and then Ellie. Jack.
Morning.
Yeah.
I think it was to address a point that Steve's just made actually, which is that it feels like proposition 1. I'm guessing there's some extra, at least one more proposition coming our way. Is there? Given it's been numbered, but proposition 1. It sounds like it's got 2 sort of potential usages. One of them is that identifying some projects, and the other one is having a single repository of data that people can access. And I think the latter sounds like it would be useful for, say, public health colleagues who haven't maybe done analysis in this space before, or for practices and PCNs who don't have all of this information together in one place at the moment. And if there was something they could easily log into, I hesitate before saying the word dashboard, but something that they could go into where they could see all of this for their practice, then based on what we've been hearing recently, I think they'd find that incredibly useful. I suppose, and this may be where we get onto proposition 2 and potentially even 3, some of the project work may identify that there are questions that this data can't address, and gaps that we would need patient level data for, or where we see that that data sets don't knit neatly together, where the denominator in dataset X is very different from the denominator in dataset Y for whatever reason, and there's some alignment work that needs doing. So it certainly feels like it would be a useful exercise, but it also feels like it might not lead to any tangible conclusions other than just sort of progressing our understanding of the data. But I think that sort of data repository for PCNs, etc., would be a really sort of useful, tangible output.
Great. Thank you very much, Jack. Appreciate it. Ellie, is Ellie next?
Yeah, Ellie?
Yeah, completely echo what Jack just said, really. I think it would be the most incredible resource, and especially from a project perspective, the teams often get funding very short notice and you have to turn something around really quickly, and it just doesn't allow you to look at the amount of data that you'd really like to be able to look at to do it. And from a practice and PCN perspective as well, I think it would be really useful for them to be able to have one place to go and look at this. We're currently pulling some sets together for our practices and PCNs in an easier to read format, but then they're only valid at the time we've done it. Whereas something like this would be so much better because it's live and it doesn't require us to sit behind it every day and update it whenever needed. So yeah, really echo the interest. I think it would be really helpful.
Great, thanks, Ellie. I'm going to suggest we go back to Menti now, and I'm going to try and capture levels of interest in proposition 1, and then I'll go on to mention proposition 2. I've only got 2, so we should be okay for time. So let me just go back to Menti. And so here's my next question for you. So thinking about proposition 1, how likely is it that you would make use of the collated data set, attend the ideas generation workshop, work on a project as part of the programme, and lastly share your code and outputs with colleagues on the MSDN? Looking good. So I guess the one that's getting less support is this idea of working on projects as sort of collaboratively, which I guess is always going to be the challenge, because whilst we might want to work collaboratively, there'll be their local demands on your time, and whether they will trump any sort of intention to work collaboratively is tricky, isn't it? But it looks like there's great support for the idea of a collated data set, and we'd get a good attendance, it looks like, if we were to hold some sort of ideas generation workshop. And even if you're not part of the sort of collaborative program, but you use the data set for something, then if we have a repository for sharing code and outputs, it looks like people are willing to share that with others on the network. So that's great news as well. Lovely. That's really helpful. Thank you very much for those who've responded. I'm just going to go back to my slides now. So next thing I wanted to talk about was these patient and record level data sets, and my knowledge here is definitely going to be below the level of other people on the call, but I'll try and give you my understanding of where we are with the patient record level primary care data sets at the moment. So I think they come in three forms. There are some national solutions, problematic. Care.data 10 years or so ago, but sort of fell flat because it was sort of badly handled politically, I think it's fair to say. GP extraction service came along after that, and off the back of that we have this GP data set for research and planning that's now available. Initially, those extracts are relating to factors that could be used or useful for COVID-related research, and those data sets are available in NCDR, but I think are going out to lots of ICSs and CCGs as well. And I think the idea nationally is that data set will be expanded in the future to cover other purposes, so that people wanting to use that data set for research outside of COVID would be able to do that. But that relies on politicians and senior managers in NHS England, NHS Digital, taking us through the process of getting agreement for that. At that point, I think you would get access project by project. You'd be able to negotiate access for a particular purpose, and you'd have access to the data for that purpose only. So it holds great hope, but there are lots of barriers to be overcome before that can become a really useful resource for all of us to use. I'd be interested to hear later if anybody has used the GDPPR data set for some COVID research. We did apply, but the application process became quite tortuous, and in the end it became too much of a hassle for us to pursue, so we dropped out of it. The timescales weren't going to help, were going to be such that the project we needed to run wouldn't have been useful in that time frame. So they're the national solutions I think are on the cards. There may be others as well, but I think those are the main ones. There are, though, lots of local solutions that have emerged because the national solutions haven't been forthcoming. Lots of individual CCGs working with third parties like EMIS Health and GraphNet to extract data from their GP practices for specific purposes, putting all the IG arrangements in place for those. And some areas have done that in a way which means they can link those primary care data sets into other data sets like hospital use data sets, for example. There's the KID data set from Kent and the Discover Now data set from North West London that I'm aware of, but I'm sure there are lots of others out there as well. I think there are certainly some in our patch too, where people have gone down the route of collating local record level data sets and linking them in with other hospital data sets. And then I think that there are these sort of research solutions that are out there as well. There are four that I'm familiar with. CPRD, which I think is DHSC owned. THIN, I can't remember what the THIN acronym is for now. Open Safely is the one that Ben Goldacre is involved in. Kernel is an offshoot of KID, the Kent data set. So they're essentially non-random extracts from a non-random sample of GP practices across the country. They all have about 10 or 15, 20% of practices in terms of coverage. Maybe Kernel has got slightly less than that because it's a local solution. And the idea is you can get access to those data sets by paying a fee, usually quite a substantial fee, and you can get permission then to use those data sets for specific projects. They all have to go through, each project you want to use it for has to go through a sort of a panel that approves the research request that you're putting to them. And this is where my second proposition comes to you. So the CSU is considering buying access to CPRD, one of the research data sets, which I think has about 10% coverage across the country. The costs are six figures. It's not a unsubstantial investment. We've looked at it several times in the past, and the fees have just been, for single projects, have just been too much for us to consider. But if we were to get approval to spend the money and to use the data sets, then we were wondering whether we might be able to provide some CPRD extract service to ICSs free at the point of use. So you wouldn't be paying for these extracts at the point you were using them. And the extract would be produced for a specific project, and you'd need CPRD sign-off for that, but we could help you manage that. And then the extract would be supplied to your local CSU analyst to work on your behalf. I think there are probably barriers to providing the full record level extract directly to you, but if you were working closely with your CSU analyst, I'm sure that you could find a way of getting the answers to the data without having to see the raw data. So again, proposition, would that be of interest to people? If we were to provide that service, would you think you'd make use of it? I'm guessing the question is whether your local solutions are sufficiently well developed to mean that that's not necessary, or if you thought that, well, getting a non-random sample of practices from across the country, is that going to give you the local perspective that you need for your projects? But anyway, we're really just interested in testing the appetite for it. Is it something you'd like us to look into? As I say, we are already considering buying it. It's whether we add on this extra functionality to allow you to make a request for extracts from the CPRD virus that would be useful. So I'm going to stop sharing my screen and open up for conversation, discussion again, if that's all right. Actually, what I'll do is before I do that, I'll go on to Menti and just ask you a couple of questions about the state of affairs of record level primary care datasets in your area. That might get us to the nub of the matter more quickly. So if I could ask whether you personally have access to a record or patient level primary care dataset. So you can answer either no, or this is back on Mentimeter now, so either no, yes, you have access to one of the national solutions, yes, you have access to one of the local solutions, or yes, you have access to one of the research solutions. I'm hoping that categorization works for you. Right, so most people at the moment don't have access to one of these record level or patient level primary care data sets, but there are quite a few people who are saying they've got local solutions in place. So I'm guessing the need for access to CPRD will be minimal for people with those sorts of solutions in place. Okay, move on to the next question now, which is about the state of your organisation plans to create these record level local solutions. So do you have a dataset already? Do you have well-developed plans to put these datasets in place, early stage discussions to put these datasets in place, or no plans at all? So given the responses, it looks like some people, there are datasets that exist, but some people don't have access to those local solutions. But for those that don't, it looks like it's some way off coming if there are either no plans in place or the discussions are really only at early stages. So thinking about the proposition I was putting to you, how likely is it that you would make use of that data extract service if we were to put it in place? Do you think it's something that you might use?
Stephen, is this, so the proposition 2, is that instead of proposition 1?
No, they're independent of each other.
Oh, right, so you can have both. You
can have both, yeah. If we could do both, if there's sufficient interest, then we would definitely look into doing both. At the moment, this is just this second one's a bit more speculative because I would have to do more work to assess the feasibility and costs of doing that. But I think where there's a will, there's a way here. So if there's enough people interested, I think we would look into it. And that probably says about, this is like a Brexit vote, isn't it? It's about half and half, unfortunately. So a lot of people saying they definitely would, but probably quite a lot of people saying they would be unlikely, or only perhaps they might use it. But I think that's enough for us to give us the motivation to go and work up a proposal in a bit more detail for you and come back with something a little more definitive so that you can engage with it and tell us whether you think that might be useful. So that's the message I'm going to take away. We're going to go away and do a bit more work on it and see if we could work something up and get a more definitive response for you about your level of interest.
We've got a hand up, Stephen. So Matthew, have you got a question?
Yeah, you were saying about the need for approval on this data. And obviously, in order to do that, I guess you'd need to kind of quite precisely specify your project. I guess a couple of questions I had on that was, A, how long does that process take? Because if you've got a kind of a project you've got to turn around quickly, and they take weeks to respond, that might become relevant. And also, as we all know, sometimes projects evolve and change. So you can't always provide at the beginning of the process a kind of full spec'd out project. So I'm just wondering what an obstacle that would be.
Yeah, I think CPRD, one of the reasons we're attracted to it is because this relates to your second point rather than your first one, but they give you opportunity to explore the data set speculatively so that when you come to specify your extracts, you know what it is you need. So you can do some preparatory work within certain limits to assess data quality and coverage and test out some methods before you commit to saying, I need this data set now for this project. And obviously you can't use the results of that early stage preliminary stuff in anything you publish or anything you make available to people. But at least it does give you that freedom, which I think the problem with a lot of these data sets is that, GDPR, one of my struggles with it is I don't know whether it's worth going through the very lengthy application process when I can't see what it is I'm going to get. And that puts me off. So I think that would help us address that question, Matthew. The question about the timeliness of the approval process, I think CPRD is relatively good, but I will check out those timescales, and that'll be something I'll try and make available to you before we formalise the proposition back to you, Matthew. I think that's a really useful question. Does that provide some reassurance, Matthew?
Yeah.
Thank you. Any other questions on proposition 2, or anything people want to go back to on proposition 1 before we? Because I think we're going to be short on time soon, aren't we, Rachel? I thought this would be a quick meeting, but we have needed the time after all.
Yeah, I think there's quite a lot of interest, isn't there? And I think that's definitely shown. Matthew's still got his hand. No, I don't think he's got another question. I think he's still got his hand up from before. I think.
I'll take it down.
It's okay. I'll just keep staring at your name. I know, that's great.
Any other questions or comments, or any other ideas people might have for other ways in which we could promote collaboration or better use of primary care stuff? Jack.
Yeah, I think. I mean, one thing I think I'd find beneficial is to understand sort of nationally as part of NHS EI, NHS Digital, etc. What plans, what sort of tangible plans there are to generate some of this going forward, because I think there's been talk about it through the GPRD. There's some G's, there's some P's, there's some D's, and there's some R's in there.
Yeah.
You know the one.
I do.
But in terms of actual sort of tangible what's and when's and anything beyond that, I think it's unclear at the moment, because what we could do is create a fantastic thing locally for the Midlands, but then there might be a national thing that then comes out 6 to 12 months later that means that whilst it wouldn't be wasted time, it's duplicating efforts. And I think the same about what we're trying to do locally. Again, is there something national that's going to come and be accessible to everybody in a couple of years' time? If there is, then we can probably all wait for that, and there's useful stuff that we can do in the meantime. So I don't necessarily know who's leading on that nationally, and I think if we can include national colleagues in these conversations, especially if we're going to be creating patient level data sets, then that feels like it would be a useful thing to do at the outset, just to get a feel for what that direction of travel is.
Thanks, Jack. I have in the past tried to get those sort of clarity from colleagues at national bodies, and they can always set out the intent, but it feels like they can't commit to anything, timescales or whether or not things will happen, because they know it relies on political processes beyond them. And because of the car crash that was care.data, they're particularly anxious about making sort of formal commitments. But that, you're right, leaves us in the hanging, doesn't it? We don't know whether to invest in local solutions because we don't know whether national solutions are coming along. I mean, the CPRD thing, you pay for it, you get an annual license for it, so we wouldn't be committing forever. So I think the overheads beyond the initial very large lump sum are relatively small. But I think it's more of an issue for you locally, isn't it? Do you go to the bother of trying to get all the IG arrangements to get extracts from your practices locally if something's going to come along nationally which will either cut across it or negate the need for it? So I'm completely with you. I think it's a shame. I'm hoping that Charlotte might have an answer for us, because Charlotte's got her hand up.
No, I think I was kind of asking the same question, really. Yeah. You know, in terms of getting hold of the GP data, like the actual patient data, the you know, like we get our sus feeds and they are, you know, from the hospital and stuff. Is there anything in the pipeline for something like that for GP? Because I mean, I've worked with GP data before, but you get, you know, across a patch with the different clinical systems, and the outputs are so different.
Yes,
it makes it really hard to work with.
Yeah.
So yeah, I guess my question was a little bit similar. Is there any rumours of a national solution for GP clinical data?
The room, I think things have moved on a little bit, Charlotte, in recently because of the COVID stuff. So COVID gave people the freedom to do what they've been planning to do for a long time, because they had some of the IG rules were relaxed, and so they made this GDPR data set available.
Yeah.
For specific questions, and it showed that it was technically possible. They could extract en masse data from lots of systems and put it into a single format. The system suppliers got on board quite quickly, and I think the intention is, as I understand it, for them to use that as a template to make this data set more widely available and useful for researchers in the NHS.
Yeah, because it would be so useful to have it.
Yeah, so I think the rumor is it's going to happen, but it's getting beyond the rumor to something more definitive about when it might happen and what the arrangements might be. That's what we're lacking at the moment.
Mm.
But it's I agree completely. It's something we've been crying out for so long,
it's just that missing gap, isn't it? We get data from everywhere else to do with the patient's care.
Yep.
But not particularly from this big repository that could fill in gaps and help with prevention, and so much good you could do with it.
Yep, completely agree, Charlotte. Completely agree.
Okay.
Rachel, are we running out of time, Rachel?
We sure are.
Well, just to say thank you first of all. Just to say thank you. I've got everything I needed from you today. So it's great hearing your feedback and your comments and answering your Menti questions. It's given me the steer I need to be able to take things to the next stage. So thank you for that.
Fantastic. Yeah, and thanks very much, Stephen, for sharing that with us, and what is possibly going to be an excellent resource for people to use as well. I just wanted to sort of finish by I haven't really got time to go over what we're going to be covering in huddles in the next few huddles, but I'll do that via email. But for next steps for this, what do we need from people who are here today who've been really supportive?
Nothing at the moment. We know who's attended the call, so we can. What I might do in the next few weeks is do a note out, setting it in a bit more detail what our plans might be, and maybe asking for people to comment on those via email if that's okay.
Okay, no, that's great. Well, thanks again. That's fantastic. It's very exciting, and thanks everybody for coming. And we'll see you in a couple of weeks when we've got the health economics unit telling us about evaluation in the NHS. Okay, it's great to see you all.
Thank you.
See you soon. Bye bye.
See you there. Thank you. Bye.
Bye, Alan. Bye.
Bye.